Hello, and welcome to the second of two podcast episodes in the series PrEP Roadmap, Where Are We and Where Are We Going? My name is Jessica Adams. I am an HIV clinical pharmacist and scientific director of infectious diseases at Clinical Care Options, and I will serve as the host for this podcast series. In these two episodes, I speak with global experts on HIV pre-exposure prophylaxis, known as PrEP, as well as PrEP users and advocates to get their insights on the potential for current and future PrEP modalities to play a critical role in ending the HIV epidemic. In the first episode, we discussed how current PrEP regimens represent a revolutionary step forward in enabling many individuals to avoid HIV acquisition, including how PrEP has empowered people to take control of their sexual lives, remarkable progress made toward HIV transmission elimination, and the importance of PrEP options that allow individuals a choice of PrEP modality that best fits their lives. In this second episode, I explore how we can unlock the promise of PrEP and the future of PrEP. I talk with experts about the barriers that have prevented the full potential of today's PrEP regimens from being delivered, how those barriers might be overcome, and how the next generation of PrEP modalities may address unmet needs and take us closer to a future without HIV. I spoke with Beatrice Grinstein, the International AIDS Society president-elect, who has been involved in a number of large seminal PrEP studies, including the PrEP Brazil demonstration project, which provided data to support PrEP incorporation into the Brazilian public health system, the Preparata study, a demonstration study of PrEP in transgender women in Brazil, IMPREP, a demonstration implementation study aimed at expanding PrEP in Brazil, Peru, and Mexico, and the HPTN 083 study evaluating injectable cabotegravir for PrEP in HIV-negative men who have sex with men and transgender women. She says that despite the major advancements that have been made in the development of PrEP, access still remains a major barrier that has prevented the full potential of today's PrEP regimens from being delivered.
So, as we know, despite the major advances in treatment and prevention, the HIV pandemic continues to pose a major global health challenge. So, despite a massive and unprecedented global public health investment, approximately 1/3 of those who have HIV are undiagnosed or not in care or not in effective therapy. So, we need to further work to get this picture better. And PrEP is one of the major strategies that we have to make this continuum of care and prevention look better than they are now. So, more than 1 decade ago now, WHO first recommended the use of oral PrEP as a prevention option for people who are at high risk of HIV infection. But by the second quarter of 2023, 4.9 million people had initiated oral PrEP worldwide. Nevertheless, despite evidence of impact on incidence in some settings and populations, we can mention London, we can mention Seattle, San Francisco. These are cities where you can find already differences in the HIV incidence, but achievement towards targets for PrEP uptake continues to lag in every region. So access to oral PrEP remains much low for it to affect the course of the global epidemic. So until very recently, PrEP use was concentrated in high-income countries. And in these settings, racial and socioeconomic disparities are skewing awareness and use of PrEP. Even in countries with widespread PrEP availability, such as the United States, inequalities are apparent in the divergent rates of PrEP uptake along racial, ethnic, socioeconomic, geographic, age, and self-identity lines. So there was a pronounced uptake of PrEP in some countries, of Eastern and Southern Africa, but other regions of low and middle income countries have seen insufficient progress in expanding the access and use of PrEP, including Western and Central Africa, Asia, the Pacific, Eastern Europe, and Latin America. So my country, Brazil, is located in Latin America, and the number of people on PrEP in Latin America has increased by over 55% since 2021. However, it is still less than 5% of the projected need by 2025. As such, many people who could benefit from PrEP are still left behind.
PrEP access and uptake vary by country and region, but remain low throughout much of the world. The most recent CDC data show that in 2022, 36% of people who could benefit from PrEP in the United States were receiving it, but there are large disparities in uptake by race and ethnicity. In 2022, 94% of white people who could benefit from PrEP received it, but only 13% of Black or African American people and 24% of Hispanic or Latino people who could benefit received it. I discussed these disparities with Kenyon Farrow, a PrEP user and advocate in the United States.
Well, so I think one of the kind of initial causes, I think, of the disparity was the initial PrEP rollout. So first, I think, because of, again, the cost of the first, medication that was approved, it therefore was going to rely on people who already had insurance and had private insurance and who could, also pay the copays. And also, if you have a physician that also was highly motivated to talk to you about PrEP from the very beginning. So you're talking about white gay men in San Francisco. To just use to put a fine point on it. I often think about there's a reason why that city, right, has had the kind of uptake in PrEP use and the kind of reached certain sort of levels on the care continuum better than any other city in the US. Small city, high concentration of wealthy white gay men with an established network of physicians and care in that town. And that's also where some of the early research happened. So there was already that kind of the word moving through the community as people were involved in those original research trials, so that when it became approved, you already had that kind of network and established, and you had gay physicians championing it to their patients, et cetera. That had a lot to do with why San Francisco had those kinds of positive outcomes early, whereas it took much longer through a lot of other parts of the country where, one, we sort of, PrEP, becomes a thing in 2012, just as the Affordable Care Act is rolling out. We're in court battles in 2012, trying to get Southern states to expand Medicaid, which in 2013, the Supreme Court decision decided that they didn't have to. So therefore, you were going to have higher rates of people who are uninsured in the places where HIV prevalence is the highest, not have access to primary health care, right? Except for initially Arkansas, and then eventually Louisiana. So these are the things that were kind of created the system of disparities, right, around, the country. And so then it's taken more work to kind of create other kinds of systems, like sort of, some states or cities have PrEP access programs for people who are underinsured, or who can't pay the co-pays of, certain medications, et cetera, or the doctor visits. So you had to kind of stand up all these things kind of over 10 years, as well as do a more kind of slow rollout in terms of just the kind of broad education around PrEP access. I'll tell you a quick story. So it was probably 2016. I was in Atlanta, Georgia, doing this work and on my way to a meeting about, PrEP in Atlanta. And my rideshare driver, Black woman in her 50s, we were sort of chatting. And so she's like, "Oh, what are you doing in town?" So I explained to her, what I was doing. And so she says, "Wait, what is that?" And so I said, "Oh, PrEP, it's, a medication that you can now take once a day to prevent HIV. It's actually better than condoms in terms of just rate of prevention." And she kind of started to well up breathe heavy, and she had to pull the car over because she got so emotional. So I'm like, are you okay? What's happening? And so she said, I have two nephews who are brothers. They're both gay. They're 21 and 25 years old. They're both HIV positive. She was like, when did this get approved? And I told her 2012, and I think it was 2016 at the time. And then she just started crying. And she was like, this was out, before they both contracted HIV. And she said, why the hell isn't anybody talking to Black people about this? Right. And I'm not getting emotional talking about it, but like that's the issue, right? And I would just say, as a kind of final point on the kind of disparities, a lot of the sort of promotion strategy where we were trying to do the kind of education programs to talk about PrEP, if you look at a lot of the social marketing early on, it very much focused on, the kind of like, you're at risk, so you should get on this, right? Which we know those messages don't work particularly for Black and Brown communities, because they already feel that, kind of society looks at them as more at risk for HIV. And so they're actually more avoidant of those kinds of messages, first of all. Second of all, I have said to people for a long time, and I think this is beginning to kind of show itself, that, for white gay men, very much are motivated around seeing themselves as a particular kind of community and an interest group, exclusive of other things and other folks. When you talk to more Black and Brown, queer and trans folks who definitely see themselves, they're out. It's not like they're in the closet. They understand that they are gay, bisexual, transgender, queer, what have you. But they think about their kind of racial and ethnic communities as often primary, right? Their primary identity. And so we weren't doing any work to speak to those communities writ large, right? Because I know for a lot of folks, it's not necessarily like my gay friends who I'm going to be more motivated, say, to start PrEP or think about things. But if my aunt says to me, I heard about this medication, like, on the news or saw a commercial, and you should think about it. Or if there's sort of more community norm setting that lessens the kind of stigma and the way people feel pigeonholed as queer people, as racial and ethnic minorities in this country, that actually would have done more, would have actually expanded how even, folks wanted to use PrEP, if we had just kind of shifted how we marketed it in those communities to really be more community-centric as opposed to sexual risk-centric, which I think set us up for, taking more time to then have to, build to at least in terms of the demand piece around PrEP, and not just a sort of systematic work as well.
Britt Williams, a cisgender woman who is a PrEP user and advocate in the United States, discussed access as a key contributor to PrEP disparities.
I think some of the barriers that are driving the disparities are the same ones that drive all health inequities in the United States, right? It's lack of access to medical care. A lot of people of color in the United States don't have primary care physicians. They're on the sort of periphery of medical care and often use sort of medical providers for acute sort of issues that they're facing and not necessarily for preventative measures. So that's one part of it, right? Is access to consistent quality medical care. Another piece is in the regimen adherence, right? So if folks don't have that access to a medical provider, they're not able to do all of the things that it takes to be an active user on PrEP, which for both the long-acting injectable and the daily oral requires you to have blood work done. It requires you to speak to a physician, to go to some sort of office or center or place where you can have labs done. And so for me, one of the things that I would love to see is that we don't necessarily need a primary care physician, or we don't need to go to a PrEP specific clinic, but I can go to the local urgent care center and I have, a request for labs, and there's a virtual doctor that I can meet with that I would be able to talk to about my prescription. I think these are things that can help to address the disparities in PrEP uptake across the US. But the biggest piece is all about access. People don't have access and they don't have the information to know that PrEP is available for them.
Another major barrier, other than access, that has kept current PrEP modalities, especially oral PrEP, from reaching their full potential is the requirement that someone who is not sick remain adherent to a preventative medication and remain engaged with the healthcare system. I spoke with Linda Gale Becker, professor and director of the Desmond Tutu HIV Center at the University of Cape Town, about the challenges many face with PrEP adherence and engagement.
So we started our first sort of iteration of pre-exposure prophylaxis as a single pill taken once a day. And the idea was that you'd have to, if you decided you needed this kind of preventive measure, you started the pill a day and you would take a pill a day. Now, for a large, significant portion of the population, particularly because they're healthy, young, fit people, the concept of taking a pill a day, even if they're not actually at that moment being exposed to HIV, becomes difficult, challenging. Maybe on a preferential point of view, I don't particularly want to be taking a pill if I'm not having sex or I'm not particularly at risk at the moment, or just the difficulty of doing something daily when you're not reminded because you're not ill. When we've got a head cold and you feel sick, you obviously are reminded to take medication, to take your therapy. If you're entirely well and healthy and getting on with life, it can be challenging to remember to do something daily. And so perhaps one of the biggest barriers that we hear repeatedly from, in particular, young people is this notion of having to do something daily. So that is one of the aspects. For others, just the notion of taking a pill is quite difficult. People don't necessarily want to be swallowing pills. The other kinds of barriers we see is just having to show up at a health facility, which is really more suited for dealing with sick people and providing therapy, is difficult because you're standing in a queue with other sick people. It might take a long time. It may, use up a lot of your time. So how we provide PrEP has been a barrier because some of our service delivery models have been quite therapeutic and quite curative in their paradigm and not really suited to healthy individuals who really have very busy lives to get on with. And then other barriers have been fairly, simple ones that we just haven't had great awareness that these interventions are available. So demand has been perhaps not as good as it should be, and to a certain extent, supply. We healthcare workers have not always bought fully into the concept of a pre-exposure prophylactic. There's often quite a lot of negative feeling about using an antibiotic or an antiviral to prevent a disease. And so we also have to overcome provider prejudice in this regard. So I think it's been a number of barriers. Where we're trying to go with this now is really to reduce those barriers as much as possible with simplification, demedicalization, and making sure that we have options around service delivery. And I think this is really important, that we move out of a therapeutic way of thinking. These are antiretrovirals, but they are being used for prevention. And so we've got to move out of the therapeutic paradigm and into a preventive paradigm.
But access and adherence alone aren't the only barriers. The World Health Organization has identified 5 key populations disproportionately affected by HIV, populations for whom they have provided guidance on targeted HIV prevention and treatment implementation strategies. These key populations are men who have sex with men, people who inject drugs, people in prisons, sex workers, and transgender people. I asked Beatrice Grinstein what was found in terms of PrEP adherence and engagement for some of the key populations in the IMPREP study, a large demonstration project in Latin America.
Although PrEP is not meant to be a lifelong prevention strategy, high adherence is needed during periods of use when an individual is at risk of HIV, what may be quite challenging to achieve, especially among the most vulnerable. So to really realize PrEP's benefits, individuals need to both not only initiate PrEP, but remain on PrEP during periods at risk. So, for instance, in studies that we have done in Latin America, such as IMPREP was a implementation study done in Brazil, Mexico, and Peru, funded by UNITAID. And in this study, we were able to enroll now 9,509 individuals who initiated PrEP. 26% of them were aged 18 to 24 years old, and 5% were transgender women. What we saw is that looking at the different outcomes, such as loss to follow-up, because this was a same-day PrEP initiation study. So we had 8% of people who received the first dispensation and never come back. And we found it quite reasonable for such an implementation project for same-day PrEP that can be a challenge. So we found this a good number. However, when you look at adherence, we look at adherence based on the medication possession rate, and individuals who were younger, transgender, and with lower education had lower MPRs. So meaning that they didn't have a drug to cover them at least with 4 pills a week. So we saw this major difference among the younger, the transgender women, and with less education. We also look at longer-term engagement in care, and we saw that overall it was not bad, 66%, but again, the younger transgender women, less educated, had the poor long course engagement. And this engagement meant come to the first visit after dispensation, 4 weeks after dispensation, and come to 3 more visits within a 52-week time frame. So in multiple studies, reasons for stopping or never initiating PrEP include, in addition to challenges in accessing the medication, low self-perceived risk, it's a very important aspect, concerns about medication side effects, or a desire not to take a daily pill, stigma, violence, mental health, or competing life events.
Although key populations make up approximately 50% of new HIV diagnoses worldwide, low self-perceived risk is common among cisgender women as well. This was Britt Williams' experience as a cisgender woman on PrEP.
You know, in the United States, people assume that PrEP is still for men who have sex with men, or it is for people who are in high-risk populations. And when I began my own journey, I was actually asked whether I was a sex worker or someone who was engaged in sex work, because it was still seen as something for men who have sex with men, people engaging in sex work, people who are engaged in sort of needle-based drug use. And so I've always thought that was interesting, because for me, if you're not HIV positive, you're HIV possible. All sex, all drug use, all of these things are inherently risky. And so for me, I think one of the major barriers is needing to shift the conversation from PrEP being a biomedical intervention for people who are most at risk to PrEP being available for everyone.
Indeed, PrEP being available to everyone and discussing it with all sexually active people would go a long way to overcoming at least some barriers to PrEP. Now let's consider another question. Can the next generation of PrEP modalities address some of the access and adherence issues that have prevented PrEP from reaching its full potential? This is what I asked Linda Gale Becker, and she shared her excitement that yes, future PrEP options may address some of the current barriers and bring us closer to a future without HIV.
The next generation of PrEP modalities are really terrific. They are the, if you like, what I call the superheroines of the day, in that they move us beyond the single pill once a day. We start to see variation on top of that, the 2-1-1 regimen. So this is event-driven PrEP or coitally-dependent PrEP, the notion that I only need to take the pills at the time that I am sexually exposed. At the moment, only recommended for men. Unfortunately, we don't have any clinical evidence for women, but that's kind of the first departure from taking a pill a day. We then move into less frequently dosed modalities. And this is very important because there are individuals who just don't want to do something daily. And we're better if we're given something that has a longer dosing interval. So here, first up is the DAPI ring. So dapivirine vaginal ring. It is a non-nucleoside reverse transcriptase infused vaginal ring, which is situated high up in the around the cervix, comfortably placed within the vagina, and does not have to be removed for 28 days. A month later, the ring gets replaced, and again, then the ring user forgets about it and gets on with their life. The terrific thing about the dapivirine ring is it works when it is in situ. When it's removed, the antiretroviral disappears and it no longer has any activity, but it also means there isn't long-lasting, lingering antivirals around. It is also very little absorbed systemically, and so it means there are far fewer kind of systemic side effects. So that is a wonderful option, obviously only for people who have vaginas, but an important addition to the toolbox. The next is the very exciting notion of a depot injectable. And here, cabotegravir long-acting is the new kid on the block. This is a strand integrase inhibitor. It has a very long-acting pharmacokinetic profile, which means it only has to be dosed once every 8 weeks. It is quite a large volume injection to the muscles of the buttock, which some people can find quite painful. But the good news, again, is it's one shot and then nothing is needed for the next 8 weeks. People who really want to get their prevention, walk out the door and not think about it for 2 months, really, I think, will benefit from this modality. So this means that we start to offer choice, which is powerful. Now, if I can use the analogy of contraception for prevention of pregnancy, we know that when we introduce long-acting reversible contraception, we really change the face of reproductive choice and outcomes for women all over the world. Because people were able to say, I will prefer this modality to that modality for this time in my life, recognizing that we're all, moving through a life course. We have different needs, different lifestyle issues at different times. Similarly, for HIV prevention, this now means that people can say, I would like to have this at this time of my life, but maybe this kind of modality at another time of my life. Or I know this suits my personality and my kind of characteristic better than that modality. There is also another element to this, that as we think about service delivery models, and we also think about the kinds of products that may have a bearing on the service delivery model. For example, we at the moment are offering as couriered PrEP, both oral PrEP and the vaginal ring. So people can first initiate and then they can get their maintenance PrEP via a sort of postal order service. Somebody brings it to them on a motorbike or in a vehicle. Clearly, it isn't going to be easy to do that with cabotegravir long-acting. And the reason is, at the moment, almost certainly we need a trained individual to administer the injectable, and that makes it a little bit harder to have the sort of postal service. On the other hand, I think there are ways we can also make that more scalable by, for example, having shot clinics or injectable clinics where the only thing somebody gets if they go to that service is to get their maintenance dose of prevention. So, I think it's an exciting time. We are imagining all kinds of new innovations to ensure that people do get access to these kinds of prevention modalities, because I believe if we can do this, we truly can have a stab at reducing new infections and move ourselves very much closer to epidemic control.
In some countries, long-acting injectable PrEP has been a revolutionary step forward in providing PrEP in a way that is less reliant on daily adherence and potentially less stigmatizing for many. But what are the unique challenges of implementing injectable PrEP globally? I explored this question with Beatrice Grinstein.
One important thing is that expanding HIV prevention options needs to be done while expanding PrEP coverage. We need to ensure that the introduction of new PrEP modalities really increases access and reduces disparities in PrEP uptake, rather than simply providing alternatives for those individuals already engaged in an oral PrEP program. And this is a major challenge. We need to expand PrEP access and not just have injectable PrEP used by those who are adapted in using oral PrEP. So the rapid development of implementation science to guide the large-scale adoption of long-acting PrEP will be vitally important to understand the outstanding issues and implementation approaches for populations who urgently need effective prevention choices. There are several planned CAB-LA implementation projects to be initiated around the globe, including in Brazil. So unfortunately, this list of implementation projects is small in face of the major need of understanding how best to implement this product in the different geographies and cultures for the populations most at need. There are several issues that can influence several advantages and barriers related to CAB-LA implementation. So it is a great issue that injectable CAB obviates the need for daily, potentially stigmatizing adherence behavior with taking a daily pill, but the individual needs to come for their appointments to receive the injections. We need to track the injections, we need to bring people to get their injections on time, and we also need to work to have a good supply chain and logistics for distribution. Also, breakthrough infections are very rare, but still unexplained. And long-acting products may have an impact on the detection of HIV infection, because as long-acting products, they impact the antibody emergence. So we have delays in antibody responses for those under long-acting PrEP. So the assessment of HIV infections in the setting of long-acting PrEP is also of concern. So the CDC guidelines oriented to use molecular testing to guide PrEP implementation, but it is not at all possible for countries in low and middle income countries to include this strategy to implement CAB-LA. So these implementation studies will be key for us to understand also in regards to the testing algorithm, what is best and feasible for our realities. Very importantly, according to an elegant modeling developed by Andrew Phillip and his group from London, that despite increases in integrase inhibitor resistance that may happen with seroconversions in CAB-LA, it is likely that the benefits in terms of reduction in AIDS-related mortality due to CAB-LA will outweigh the risks. Although this study was done in the scenario of the HIV epidemic in Africa. As you also know, they have signed a voluntary licensing agreement for patents relating to CAB-LA for HIV PrEP to help enable access in least developed, low-income, low-middle-income, and sub-Saharan African countries. So through this agreement, 3 generic manufacturers will have the opportunity to develop, manufacture, and supply generic versions of CAB-LA for PrEP in 90 countries, of course, subject to regulatory approvals. However, this license needs to evolve to encompass technology transfer to shorten the time for generic availability, as it may take 3 years for the products to come to these countries where they can be purchased. It is very problematic that with the current direct and indirect territorial coverage, including in this license deal, there are still far too many people left behind, including those who stand to benefit the most from this scientific advancement. For instance, my own country, Brazil, with well-established generic manufacture capacity, is completely out of any possibility to produce or purchase generics when they become available. And access completely relies on a price agreement to be negotiated between the producer and our government.
Dr. Grinstein also shared her hope for future long-acting PrEP modalities to overcome some of the current barriers to PrEP.
Cabotegravir is also in early stage investigation as a subdermal implant, also in a new preparation with even more extended PK and potentially as a topically applied microneedle patch. These are studies that it will take good time for us to have these products available for larger clinical trials to evaluate them. So other delivery systems, including a subdermal implant, is also under study, and a novel-based insert for either vaginal or rectal use containing a combination of TAF and elvitegravir is in more advanced stages of development. So there are other strategies. I would also like to say a word about lenacapavir. Lenacapavir is a novel parenteral administered HIV-1 capsid inhibitor, now in development both for PrEP and treatment. So lenacapavir has a remarkably long half-life and needs to be only administered as a subcutaneous injection every 24 weeks. It appears to be safe and highly effective, working against both wild type and multi-drug resistant HIV. So one important thing about cabotegravir is that failures can occur, and this, although very, very small numbers of failures on Cabo-LA have been seen, in some instances, integrase resistance is a feature of these seroconversions. So the problem with that is that our first line ART most used and in our first option in the WHO guidelines is based on an integrase inhibitor, dolutegravir. So we still don't know if this potential resistance may or not impact the outcomes of the first-line therapy that is already implemented. So for lenacapavir, this is not an issue, as as a capsid inhibitor, it is not used as a first-line regimen. So I think this is an important feature. The prolonged administration interval can be of substantial advantage, although the subcutaneous route may result in maybe injection site reactions that may impact its implementation. But we need to wait for the results of the two large phase 3 trials that are ongoing, the PURPOSE 1 and PURPOSE 2, that are evaluating lenacapavir for HIV prevention among MSM, non-binary, transgender individuals, and cisgender women in several countries across the globe. So just as a final word, I would like to remember that inequalities are a major driver of the HIV epidemic, which continues to disproportionately burden vulnerable populations despite the availability of effective prevention and therapeutic interventions. Our current models of HIV prevention delivery are not responding to the needs of these populations. So the gaps in HIV responses and resulting HIV infections and the AIDS-related deaths lie upon faultiness and of inequality. the most vulnerable populations struggling with poverty and social inequalities are the ones that suffer the most from HIV. So hopefully long-acting PrEP does not deepen the already profound inequalities we are facing with implementation of oral PrEP. On the contrary, may long-acting PrEP be a step forward in our effort against inequalities.
I also asked Kenyon Farrow and Britt Williams, as PrEP users themselves, what they are looking forward to for future PrEP modalities and how they think future PrEP options may overcome some of the barriers to PrEP discussed. They shared the hope that there will be many more long-acting and insertable options to come.
I'm really excited about, one, the kind of advent of long-acting products on the market and giving people the ability to only see their doctor 6 times a year for, a shot, as opposed to daily medication. I think will be really transformative for a lot of people for whom they don't, want to take a daily pill. I actually heard from some providers, especially as we're trying to expand PrEP options to women who may be vulnerable to HIV and at risk, that for a lot of, I talked to a physician in Atlanta who said this, that for a lot of her patients who are women, they only would consider the injectable, right? For the reasons of privacy and, not having the pill form medication around in terms of just dealing with the stigma. So, I think that the more we have, options available, the more people will see themselves. And I'm really looking forward to, even, injectables that are even less time, right, that I think are on the horizon, or some single use products, right, that, maybe more like suppositories that last, over, 24 hours or whatever. So I'm really hoping that, we continue, in this country and around the world to really sort of, have the kind of research that allows us to develop some other kinds of novel products that will make it much more possible for more people to be protected from HIV, on their terms.
When I think of the future of PrEP modalities and what's sort of making me excited, I want to see even more long-acting injectable options. I want to see some orals that aren't necessarily daily. I would love to see something that's maybe weekly, right? I think about the advancement of birth control a lot when I'm thinking about the advancement of PrEP. I would love to see something that is insertable that people would be able to use. I would love to see some subdermal implants that people would be able to sort of consider, right? So that we're not necessarily thinking about or having to address some of the barriers that people have to PrEP relating to housing insecurity or access or medical providers. But here's your 3-month supply. It doesn't have all of these storage requirements. You can still use it. And in a few months, you can come back and take it. And so I think for me, I'm excited about the range of possibilities for different PrEP modalities and considering what the future of PrEP could look like if we have that more on demand, right? I have been saying since I've thought about sex education in public schools, even until now, that some of these things need to be available in a vending machine, in a lobby, at a hospital, or at a clinic, or at any sort of medical facility where some of these things are available, at the pharmacy in your neighborhood, right? I would love to see those kind of things available for people to be able to pursue. Well, then the last thing I would add is that for us to end the HIV epidemic, we need to make PrEP widely available in both our marketing and access to the actual biomedical interventions. And the faster we do that, the easier we can reach, the end of the HIV epidemic.
In this episode, we heard from experts around the world on barriers that have prevented the full potential of today's PrEP regimens from being delivered. They talked about disparities in access, challenges with adherence, and misconceptions on who could benefit from PrEP. These experts shared insights on how those barriers might be overcome and their hopes for future PrEP modalities to take us closer to a future without HIV. I want to end this podcast series with a final message from Linda Gale Becker from the Desmond Tutu HIV Center at the University of Cape Town.
Of course, prevention can only work if it's used and if it is available. And it is so important that at this time when we are heading towards the 2025 mile marker on our way to the 2030 targets, that we really do as a field, as a global response, that we ensure that primary prevention is available to all who need it. And this means, really making sure that even these newer modalities that hold such promise, that we do make sure that they are available to all throughout the world who need this kind of protection. And that does mean they are going to have to be available, manufactured to the level that they are made available throughout the world, but also that they are affordable. And this is where I think, again, a lot of attention needs to be in the next months to a couple of years, that when new modalities come along, they are in fact globally and equitably available for all.